Okay, good morning. Today I'd like to talk about factors associated with the discontinuation of fertility treatment. It is based on a paper published last year in 2024 from some Chinese authors looking for factors associated with the discontinuation of fertility treatment, and it's a scoping review. And basically they made the comment that even though infertility is a global health issue affecting 48 million couples, and 186 million people of reproductive age, and knowing there is basically a cumulative chance of pregnancy in the first cycle could be as high as 40%, despite these well-known benefits of fertility treatment, many choose to discontinue treatment before achieving a live birth. And this reported prevalence is thought to be in the order of about 55%. So by way of welcome and disclaimer, my name is James Danger. I have a PhD in embryology, and I've had more than 50 years in the industry. The videos are my attempt to bridge the gap between information you may need for your fertility treatment and the most recent publications available to your clinic staff. I'm not a medical person, and this information is not medical advice, but it may help you in knowing what questions to ask about your fertility treatment with your doctor, and maybe to help in understanding the advice that you receive. This page always in each video is allocated to potential support of IVF daily. I'm just starting out, but if you'd like to promote your company or clinical product, this may be the page that you may like to take advantage of. In supporting my IVF Daily channel, it may mean that an IVF client becomes a better informed IVF client, which is always good. You can click subscribe or become a sponsor, or just make a donation to my GoFundMe page to help others on their fertility journey. So the paper. The authors identified 42 factors associated with ceasing treatment, but most of them belong to 5 different groups: patient-related, socio-economic, treatment, condition, and healthcare. The study looked at over 37 articles involving more than 40,000 infertile patients from 13 countries. But they identified that female education level, social support, and insurance coverage levels decreased the likelihood of treatment discontinuation. That is, they continued treatment. So the better educated a woman was, the better social support and the better insurance coverage they had, couples are more likely to continue treatment. But the reverse is also true, that poorer female education, less social support, and poor insurance coverage did lead to an increased likelihood of stopping treatment. Whereas multiparous women, male infertility, depression, higher infertility duration, and treatment duration all increase the likelihood of treatment discontinuation. What a mouthful. In other words, there are some factors you can influence and some factors you cannot influence. Managing expectations, counselling, information, and support are ways that clinics can influence a couple's decision to comply. I'll talk about that in a minute, with a recommended treatment plan, if ever there was one. And in this graph, the authors identified all the different factors that may be part of the decision-making process of a couple to continue or discontinue. And I actually think this is quite a good chart. It probably would be worthwhile most clinics going to the paper, getting a copy of this form and using it inside every couple's file to give an indication to the clinic whether couples are at risk of discontinuing or not. The social factors include aspects like the women's men's age, their education level, their parity, ethnicity, marital status, income, man's history of infertility, the distance between home and the hospitals, and other social cultural values. The patient-related factors include BMI and FSH, smoking, support, and their varying degrees of anxiety, negative perception, and marital strain. Of course, the types of infertility categories and duration, the number of embryos have frozen, and the number of transfers, pickups they've had, and the sperm quality are all condition-related factors. There are several healthcare factors, including the level of coverage, differences between fertility centres, provider types, and providers' guidance. And of course, the treatment-related factors include types of treatment, the duration, number of treatment cycles and success, degree of ovarian stimulation, the time between treatments, and the number of previous failed cycles. So both of us said age educational level, and ethnicity are the common non-modifiable factors for treatment discontinuation, while insurance coverage, depression, and anxiety symptoms are among the more commonly reported modifiable factors. This review also proposed that discontinuation may be attributed to patient-related factors, in particular anxiety and depression and social support, but also the healthcare system-related factors. In other words, it's a financial aspect. In a 2013 study, the authors looked for compliance of couples attending to their treatment cycle. In this case, the authors considered 3 cycles of treatment as compliance of a treatment cycle course, and discontinuation is not completing this course. Now, most clinics don't talk about having a course of treatments. They talk about one treatment at a time. But if they, right from the outset, clinics gave couples a concept that several cycles of treatment may be required, it allows them to budget both the time and money and other social factors to allow them to meet a 2 or 3 or 4 cycle course of treatments in a respectable time. Compliance is likely to decrease with ART failure from 82% after the first cycle to 75% after the second failed cycle. And this decrease did not appear to be a function of the efficacy of the clinic, but more to do with their personal factors into social support, etc. A typical treatment regimen compliance rate of 78% in a patient population was expected to undergo treatment until they received pregnancy or were recommended to stop treatment. So that's 22% of people did not complete a course of IVF treatment cycle. And they argued that if you take for every 100 couples starting IVF treatment, 78 may be expected to comply with 3 cycles of treatment, and of these, 43 may expect to achieve a pregnancy or a live birth. However, if full compliance could be reached, that is, patients could be supported to continue, then instead of 43, you would have 58 patients who would have had a pregnancy or a live birth, representing an increase of about 15% on your success rate. The authors also reported that only 60% of women deciding to stop fertility treatment were actually satisfied with their decision, and most felt they lacked the necessary information and support. That was in 2005, and one would hope that in the last 20 years things would have been better, but I suspect it will not be. Explicit information that ART success is likely to require multiple cycles, and that treatment may entail emotional and physical side effects and disruptions to daily life, for example, would help address issues previously cited as causes of discontinuation and help couples have a more realistic expectation of what a typical ART regimen entails for an optimal chance of pregnancy. And I think this is both at the clinical level and the counselling level right at the very start. So in another study in 2024 looking at dropout not in IVF clinics but in a doctor's management, they asked the question, what is the frequency and the associated factors of very early dropout following an unsuccessful clomiphene gonadotropin treatment? And the success of infertility care has been tarnished by very high dropout rates. And fertility care dropout has been considered as resulting principally from financial barriers because of the high cost of treatment. Nearly all previous work addressed the dropout following IVF and ICSI, but factors associated with dropouts following clomid and gonadotropin at the clinical level and also needs to be investigated. And they identified that even though you may have free treatment, almost 1 in 4 women had a very early dropout following unsuccessful treatment, with patients below the poverty line being more likely to drop out early. But it's more complicated than that because they showed that the study showed an association between very early dropout and the type of care received. So very early dropout was more frequent when the first treatment cycle was clomid as prescribed by the GP and where the woman had no fertility tests or any other monitoring, so very much alone. These findings require further research as it may have important public health and policy implications in infertility care. More specifically, it will be necessary to investigate how much GPs are aware of good practice for infertility treatment, as well as the reasons for omission of infertility tests and monitoring. And interestingly enough, they made the comment that amongst women unsuccessfully treated with clomid gonadotropins, excuse me, 22% dropped out of fit care within 3 months. Multivariate analysis indicated that both younger women below 25 and older women over 35 were more likely to drop out, as were those below the poverty line, as were those treated with clomid citrate by the general practitioner, and as were those who lacked any other fertility treatment and monitoring. That is, the GP is a large gateway through which couples need to go. In another study looking at dropout after the first consultation, this was in May 2025, the Italian group, they asked what are the key factors that influence couples' decision not to return for fertility treatment after their first consultation. These are people that don't even get to an IVF clinic. What is already known, though, is the previous research has highlighted psychological, financial, and demographic reasons behind high dropout rates in IVF. Yet a comprehensive understanding of the factors driving non-return, particularly after the first consultation, is still lacking and warrants further study. But the authors did suggest that advanced maternal age, lower ovarian reserve, and eligibility for heterologous fertilisation were the primary determinants for non-return among couples, and I thought this was rather interesting. So between 2012 and 2021, 25% of couples did not return after the initial consultation, with older couples and diminished ovarian reserve as significant predictors. In 2021 alone, of 3,214 couples, 986 or 30% did not return after their first consultation. They were all contacted, and the response rate of 85% indicated that non-returning women were significantly older and exhibited lower AMH levels and higher FSH levels. That suggests that non-returning women were not returning because they felt that they were perimenopausal and there was little hope of treatment. But when you go back and look at it, the primary reasons for non-return included eligibility for donor gametes. So the couples, even though they may be menopausal, may be looking to use donor gametes or whatever that could also be donor embryos for a source of pregnancy, and there are limits to what they have access to. Interestingly enough, even though we're talking about perimenopausal, 30% of them had a spontaneous pregnancy, so it makes the question whether they are truly menopausal. And transferring treatment cycle to another centre, this is always an issue, because if you want to dissuade people from having treatment, the natural course of event is not to stop, but just to go to another clinic. So there is an impetus for the first consultation is to encourage people to continue. Other contributing factors including existing parenthood, psychological distress, and 8% were dissatisfied with the doctor. So what implications of this study was that that is consistent with what has been found elsewhere, and the study underscores the need for tailored support and counselling to address the many challenges faced by couples, particularly potentially enhancing their treatment adherence and outcomes. So my final comments will include, one paper talked about compliance to a schedule of 3 treatment cycles, yet most couples and clinics see each cycle as independent and only will be reviewed after that's been completed. But there may be value in clinics very early on telling the couples that there is an advantage in setting their sights for 2 or 3 or 4 treatment cycles and allowing them to budget to do that. The cost and socioeconomic factors, age, are the driving issues facing couples with support. Also important. Better return rates mean more couples will become pregnant and the clinics will become busier. It seems that some couples could be marked for better support, and if given, then maybe dropout rates will fall. So not all clients are equal in their needs, and recognising a subgroup at greater risk of not returning for additional treatment may allow for more focused support, information and counselling. There does appear to be some issues about access to donor material, and a lot of the initial contact were from women with very low ovarian reserve who were just exploring their last option but possibly not really interested. It may also be of value to see IVF as a course of treatment to allow them to have a management plan and to budget that accordingly. It may also be of value to identify those couples at risk of discontinuing treatment and focus support towards them. Clinics may like to use the checklist shown previously as a guide to identify such couples. Maybe we also just need to recognise that IVF these days has become very complicated and very expensive, and somewhat unnecessarily so. And we also need to recognise that many couples discontinue treatment before they even see a clinic for advice. And on that point, I think I'll stop. I'd like to thank you for your perseverance, but I do recognise IVF as a personal journey that involves the actions of many different people, and it helps to understand all these aspects of the treatment of that journey. I hope this information may be of value, and if you like it, tell everybody else about this program. I'm keen to develop it. Thank you.